Care of the patient undergoing assessment of pregnancy. What are the different methods of assessment during pregnancy? FHR assessment. Doppler ultrasound. Detects FHR by 10 to 12 weeks. Fetoscope. Detects FHR by 18 to 20 weeks. Expected rate, 120 to 160 bpm, regular rhythm. Common diagnostic procedures in MCN. Alpha-fetoprotein levels. Purpose, assesses the presence of neural tube defects and Down syndrome. Nursing alert, an elevated alpha-fetoprotein level indicates neural tube defects and a decreased level indicated Down syndrome. Amniocentesis. Purpose, to assess fetal growth and maturity, to determine genetic disorder and sex of the fetus. Nursing alert, if done between 14 to 16 weeks of gestation, the purpose is to assess for chromosomal aberration or other disorders. If done after 35 weeks of gestation, the purpose is to assess fetal lung maturity. Instruct the patient to void ID gestation is greater than 20 weeks. Position the patient on supine. An L/S ratio 2:1 indicates fetal lung maturity. Advise the patient to report fetal hyperactivity or hypoactivity, vaginal bleeding, chills, fever, fluid leakage and vaginal discharge. Complication include placental, cord and bladder puncture. Apgar scoring. Purpose, the first Apgar score detects the cardiorespiratory nervous functioning. The second Apgar is used for planning nursing care. Nursing alert, scoring is done twice at 1 and 5 minutes after birth. 5 criteria: appearance, pulse, grimace, activity and respiration. Interpretation. 0 to 3 poor, needs resuscitation. 4 to 6 fair, needs suctioning and oxygenation. 7 to 10 good, needs only admission care. Assessment of Lochia. Purpose, to detect the presence of infection and bleeding. Nursing alert, the normal color of Lochia is as follows. Lochia rubra, reddish, 1 to 3 days postpartum. Lochia serosa, brownish, 4 to 10 days postpartum. Lochia alba, whitish, 10 to 14 days postpartum. The longest possible time for the patient to have lochial discharge, alba, can be up to 3 weeks to 60 days postpartum. Chorionic villi sampling. Purpose, determines some genetic aberrations. Nursing alert, instruct the patient to drink water to fill the bladder to aid in the attainment of the desired position of the uterus. Explain to the patient the risks involved include spontaneous abortion, infection, hematoma, and intrauterine death. Contraction stress test, oxytocin challenge test. Purpose, indicates uteroplacental insufficiency and identifies pregnancies at risk. Nursing alert, interpretation, negative result indicates absence of abnormal decelerations with all contractions, positive result indicates abnormal fetal heart rate decelerations with contractions. Coombs test. Purpose, direct, used to test antibodies on patient erythrocytes. Indirect, used to test antibodies on patient serum. Nursing alert, a positive direct Coombs test indicates erythroblastosis fetalis. Direct Coombs test is helpful in evaluating transfusion reactions. Fetal heart monitoring. Purpose, assesses fetal heart rate abnormalities. Nursing alert, early decelerations indicate fetal head compression, reflex mirror image in the monitor, no treatment required. Late decelerations indicate placental insufficiency, reflex reverse mirror image in the monitor. Administer oxygen. Variable decelerations indicate cord compression, reflex U or W shape image in the monitor, change the patient's position to left lateral recumbent and administer oxygen. Guthrie capillary blood test. Purpose, used as a screening test for phenylketonuria. Nursing alert, normal level is 2 mg/dl. Provide the patient a high-protein diet, 24 to 48 hours before the test. Hysterosalpingography. Purpose, determines patency of the fallopian tube and to detect pathology in the uterine cavity. Nursing alert, involves X-ray examination and administration of a radiopaque dye into the uterine cavity. Laparoscopy. Purpose: evaluates pelvic pain and infertility and treats endometriosis lesions. Nursing alert, NPO before the procedure. Enema is administered prior to the procedure. Shoulder or abdominal discomfort is expected after the procedure due to the use of carbon dioxide. Mammography. Purpose: detects the presence of breast tumor. Nursing alert, instruct the patient to avoid the use of deodorant, talcum powder, lotion, perfume, and any ointment on the day of the exam, as these contain calcium oxalate which may crystallize and may give false positive result. Instruct the patient that the breast will be placed between two X-ray plates. Provide health teaching relates to self-breast exam. Best done a week after menstruation. Position: lying down with pillow under the shoulder of the breast being examined. Non-stress test, NST. Purpose: assesses fetal activity and well-being. Nursing alert, reactive test acceleration of fetal heart rate of more than 15 beats per minute above baseline FHR lasting for 15 seconds or more. Non-reactive test acceleration of FHR of less than 15 beats per minute above baseline FHR. May indicate fetal jeopardy. Pelvic ultrasound. Purpose: detects abnormalities of the organs in the abdomen. Nursing alert, increase fluid intake 30 minutes to 1 hour before the test in order to distend the bladder, as it is necessary to promote visualization of the organs. The patient would therefore need further teaching if she voids before the test. Standards on prenatal care. What is the standards on prenatal care visits? Monthly prenatal visits until 28 to 30 weeks, every 2 weeks until 36 weeks, and weekly from 37 weeks delivery. If there are risk factors, concurrent problems, or disorders, prenatal visits will have more frequency. What are the common laboratory examinations in prenatal visits? In the Department of Health Standards, complete blood count, hemoglobin, urinalysis, urine test for protein, random blood sugar, blood typing. What are the common medications given in prenatal visits? Supplementation of iron, 60 mg elemental iron, with folic acid 2 tablets daily on the 5th month until 2 months postpartum. Low-dose vitamin A supplementation, 10,000 IU, in 2 weeks. In endemic areas, 1 iodized capsule to all pregnant women. In areas with malaria, 2 tablets chloroquine phosphate, 250 mg/tablet, every week for the duration of pregnancy. 0.5 ml of tetanus toxoid, IM, in this schedule. The schedule of tetanus toxoid injections are as follows. Tetanus toxoid 1 will be given during the first contact or as early as possible in pregnancy. There is no expected duration of protection. The second dose of tetanus toxoid will then be given 1 month after TH. A tetanus toxoid 1 protection will last 1 to 3 years, or 80% of protection against tetanus will be received BYT the pregnant woman. Next is the 3TRD tetanus toxoid will be given 6 months after the second dose during subsequent pregnancy, 95% of protection and at least 5 years in duration. TT4 will be given 1 year after the TT3 or during subsequent pregnancy, 99% protection, and last up to 10 years. The last dose of tetanus toxoid will be given 1 year after the 4th dose or during the subsequent pregnancy. Will receive protection for all childbearing years or possibly longer and get 99% of protection. What are important nursing considerations in supporting the woman and her family? Provide psychological support by using caring behaviors. Keep families together, answer questions truthfully. Provide opportunities to see and hold the newborn. Provide photographs and other mementos. Provide choices. Assist parents in planning how to tell other family members. Give them access to bereavement education and counseling. Provide follow-up care. Help them prepare for subsequent pregnancy. Test for fetal well-being. What are some pointers in auscultation of the fetal heart rate? Place the bell of the stethoscope over the area of maximum intensity of the FHR. What are some pointers in auscultation of the fetal heart rate? Place the bell of the stethoscope over the R of maximum intensity of the FHR. Place your finger on the maternal pulse to differentiate from FHR. Count for 30 to 60 seconds. If there is an elevation or a decrease of FHR from the normal range of 120 to 160 bpm, do a recounting to validate and associate with other factors, as needed. What are the types of fetal heart rate patterns and their causes? Types, description and causes. Baseline rate determined over a period of 10 minutes. Bradycardia 100 bpm for at least 10 consecutive minutes, chronic hypoxia, beta blockers, dysrhythmia, prolapsed cord. Tachycardia greater than 160 bpm for at least 10 consecutive minutes, due to acute, short-term hypoxia, tocolytic drugs, maternal stress, fever, hyperthyroidism. Marked variability, persistent cyclic fluctuations greater than 25 bpm amplitude, stimulants like cocaine, amphetamines, tocolytics, sudden hypoxia. Minimal variability 5 beats amplitude, due to sleep, narcotics, barbiturate, CNS depressant. Absent variability, undetectable fluctuations in FHR, due to severe hypoxia. Early deceleration, similar pattern to uterine contraction, decrease in FHR at start of contraction and ends when contraction also stops, due to head compression or pressure of fontanelles on cervix. Late deceleration, FHR decreases at peak of contraction and decreases after contraction has ended, due to uteroplacental insufficiency and may lead to CNS hypoxia. Variable deceleration falls to 90 bpm, lasts greater than 50 seconds, due to cord compression. Prolonged deceleration, abrupt decrease of 15 bpm for 2010 minutes, falls 90 bpm, due to prolonged cord compression. What are the common interventions to improved fetal heart rate patterns? Maternal position changes, avoid supine to prevent compression of vena cava thereby causing hypotension, use knee chest when there is suspected cord compression, side lying to promote placental circulation and increase renal blood flow. Reduction in uterine activity, best done by reducing oxytocin administration, maternal side lying position, administration of tocolytics. Administration of 4 fluids to improve maternal intravascular volume and protect from decreased placental perfusion. Oxygen administration can improve fetal oxygenation. What is the significance of mothers doing a fetal movement count after 24 weeks of pregnancy? Fetal movement reduces in hypoxic states due to decreased oxygen consumption and need to conserve energy. 03-4/hour is an indication for referral. Cardiff count of 10 means that having less than 10 counts in 10 hours calls for further evaluation. What is the significance of doing amniocentesis, a transabdominal needle aspiration of 10 to 20 ml of amniotic fluid for laboratory analysis? At 12 to 14 weeks, detects genetic abnormalities but carries the maternal risks of infection and Rh isoimmunization, in a Rh-negative mother, and 0.3 to 0.5% risk of fetal loss. At third trimester, detects pulmonary maturity by testing the lecithin sphingomyelin, 2:1, ratio indicates adequate surfactant and mature fetal lungs, phosphatidylglycerol, Pg, and phosphatidylinositol, Pi. Test for hemolytic disease using bilirubin concentration. What are the important nursing responsibilities in amniocentesis? Informed consent. Position: supine with a rolled towel or pillow on right buttocks to decrease pressure on vena cava and aorta. Abdominal preparation. Vital signs: maternal BO and FHR before and after. Rest and avoidance of strenuous activities like jogging and aerobic exercises for 1 to 2 days. What is the significance of performing alpha-fetoprotein plus screening on maternal serum at 16 to 18 weeks of AOG? The production of estriol by the placenta is dependent on the function of the fetal adrenal glands and liver. A reduction in 50 to 60% of the previous value of estriol or progressive decrease in serial values is suggestive of fetal jeopardy. What is the significance of performing alpha-fetoprotein plus screening on maternal serum at 16 to 18 weeks of AOG? It is 60 to 70% accurate in detecting Down syndrome, low serum level of AFP, unconjugated estriol, higher level of HCG, 85% accurate in detecting open neural tube defects. Thank you.